Dear colleagues, it's a great pleasure to welcome you here in the Medtronic-sponsored Mitral Symposium on innovations in TMVR and the Intrepid trial updates. I think it's an exciting time to move over from an aortic therapy to a mitral replacement therapy, and I'm happy to do this session here with a number of friends. Alison Duncan here at my side, Ms. Petronio, Henrik Trede from our side will come later as a heart surgeon, Thomas Medin, well known, and he will introduce our knowledge journey at the moment, and Asim Lateef from New York, who is experienced in this therapy. And I'm happy to introduce this session where we'll learn a lot how we can overcome certain issues of no-tear options in patients that have short leaflets, that are unable to be clipped in order to treat these patient groups. And I would also, as moderator of the session, encourage you to use the digital forms in order to communicate with us and to send us questions on these highly innovative and highly futuristic options. So with no further delay, I would like to ask my friend Thomas Medin to set up the stage of the Intrepid journey. Thomas, please.
So, good morning, everybody. Back in 1961, President Kennedy launched this APOLLO project and program, which took them 12 years to achieve it. So, Intrepid journey that we're going to talk about today is more or less the same. We're still not in the same time frame. But it's very important to know is, if we want to know where we want to go, we have to know where we started from. Intrepid valve, as you can see it here, just to get familiar with those who don't know it, is a double disc, nitinol-based frame. The outer disc conforms with the anatomy, and the internal disc houses a pericardial bovine valve of 27 millimeter diameter. So we started in 2014, where the program has been launched. Many things has happened, and this is very important to keep in mind because you know that many people here in the room are asking why TMVR journey is so long. Why is it delayed? Is it delayed? It's delayed because the challenges are a bit more. But again, the target is so important. We need to take our time, and we need really to take the right decisions if we want to succeed. We are going to walk on the moon. So 2014, the project has been launched. This was phase 1. Some iterations has been made. And then we moved from phase 1 to phase 2. 2020, it's 2 years ago, slowed down a bit by the COVID. And now we are 2022. I'm going to tell you where we are and where we want to go. So let's talk a bit about phase 1. We have learned a lot. So there are things that has been going there, but we have learned a lot. And based on this learning, we have been constructing what we have today, but also where we want to go in the future. So we pulled data from the global pilot study, in which we have been involved. The APOLLO randomized trial has been also enrolling, and the APOLLO single arm showed later on. And these different designs are also a sign of adaptability of Medtronic to reach, again, the target and take the appropriate way. Remember at that time, all the valves were implanted transapically. And transapically because this was the best way for these large valves with large bores to be implanted in high-risk patients. So it was a good thing. It was high-risk procedures, it was a learning curve procedures, but we have data now at 1 year, but also at 2 years. Patients were at high risk or denied for surgery, literally not operable, literally not probably treatable alternatively. The all-cause of mortality at 1 year was 26, which is very acceptable for these kind of patients, and it increased a bit at 2 years. The stroke rate was low. We had some complications of bleeding. Again, this was a surgical access, as you can see it here. But again, we made some progress. Based on that, we have learned also a lot of things. We had a lot of patients that have been excluded. Some of them were approved. And the reason of exclusions are risk of LVOT, annulus size, moderate MR, LV volume size, which helped us fine-tuning the selection of these patients and probably pushing the engineers to their limits to have better devices and better accessories. We learned that a great majority of patients have been excluded because of their large anatomy, which this is something that on which we can have an action. And this is why also we are expecting the 54 millimeter valve. We have only 2 sizes so far. Azim will talk about it later on, but we have the 42 and the 48 that we are using for the studies. The 54 is going to show the XL one. And you see, if you look at the red histogram here, you see that the great majority of patients excluded needed a large valve because they are referred late also. We understood a bit more the TMVR treatment, as I've said about it here. And we have already, a small number, but we have 42 patients with data up to 3 years, which is really important for us. So look at these patients that have been included. Elderly patients, prior CABG in more than 35%, those was redo access surgery, COPD high, endocarditis, some of them, prior PCI, prior stroke, and the majority of them had secondary mitral regurgitation, again with the dilated and sick ventricles as reflected by the low ejection fraction or the impaired ejection fraction. So these patients, we don't like them actually, we don't want to treat them. What was important to show is this. With the Intrepid TMVR, we have been able to tackle mitral regurgitation. So we are not reducing mitral regurgitation, we are eliminating mitral regurgitation. And this is sustainable over time. This is very important, up to 3 years. When you eliminate it at baseline, you eliminate it afterwards. And this is not achievable with any repair system so far, at least with this kind of follow-up that we can show here. Hemodynamic, effective, mean gradient go down, LVOT gradient also. This slide shows something very important. Even in FMR patients, we have a positive remodeling of the left ventricle, which has a benefit on the patient. So it's not true that we should not treat a mitral regurgitation. It's very important. And look, the results are getting better and better over time. And I think one of the most important components here is the elimination of mitral regurgitation. The second phase, we learned again a lot. We adapted the strategy of the study. MitraClip appeared, it has been approved in US and elsewhere also, and we needed to compare the TMVR to something which is now the gold standard. So the design has changed also, as you can see it here. We knew also that we have been eliminating a lot of MAC patients, and MAC patients are much more than we think. MAC patients also, even if you treat them with the TEER, they don't have optimal results. So we thought, and we still believe that replacement is a chance for these patients. So we have been rolling in patients in the primary cohort, but also in the MAC cohort. And this is what is MAC about. Of course, we're not going to include unacceptable, spiky, severely calcified, irregular calcifications because the valve itself will not anchor correctly, and we will have a risk of paravalvular leak. But all the others are a good candidate. This is one of the implants within the MAC cohort, as you can see it here. We're going to enroll up to 300 patients. It's going to be a huge experience that we're going to accumulate. So now we are stick to this red flag, I would say, red part of the slides. We are only able to enroll patients who are not good candidates for TEER, because we need to build this evidences in this category of patients. But I'm sure that in the future we will doing different patients also. We are investigating anatomies, but also clinical patients who are not suitable for TEER. Of course, the MAC patients, multi-cleft leaflet patients, multi-regurgitant jets, severe Barlow disease that we know at the end, it may not be, they may not be treated optimally with the edge-to-edge therapy. So now we are here, we are enrolling in USA, both using transapical and transfemoral devices. The most important thing is that we knew from the beginning, and this is also pushed by the safety of the edge-to-edge repair, that we need a transfemoral system. And we are happy to announce now that all the current implantations are using transfemoral delivery. I will not extend more than this because Azim will show you about that. He will let you know about it. So more than 350 valve implants now, more than 50 with the transfemoral cases in the APOLLO. And we have data up to 5 years that we are able to show and share with you. I'm very happy to say that APOLLO EU is going to start enrolling very soon in Europe, which we co-lead with Stefan here. And also we know that a randomized controlled trial comparing TMVR to edge, which is going to start soon. So the APOLLO expansion in US, the APOLLO EU trial, which is we're going to be starting early 2023. And the Transfemoral 29, which will be the smallest one for this type of devices. The 54 valves that's going to appear. So step by step, we have built a program that's going to answer all the unmet needs to treat optimally all our patients. This 29 profile is going to increase even the safety and the accuracy of the implant. So we've done a lot of things in the past 8 years. We generated and we accumulated data and evidences that are helping us or helped us already having better tools to answer these unmet needs, to treat optimally our mitral regurg patients, but also the MAC patients. Of course, currently the major focus is in enrolling for the APOLLO, TA and TF, but there is almost no TA now. Further studies will determine if Intrepid TMVR has a broad application in mitral valve disease. And the other speakers today will focus on this part of the talk. Thank you.
Thank you, Thomas. Thank you, Thomas. And with no further ado, because we will have the audience interactions and prepare your questions, of course, I would like to hand on, and we learned in TAVR that the access is key. And so it's my great pleasure to introduce Asim Lateef now from New York, who will lead us into the latest EFS outcomes for transfemoral access, and we'll see what this changes to the therapy. Asim, please.
So, Thomas, just remind me, am I walking on the moon or am I going to Mars?
You're already there.
I'm already on the moon. Okay, great. So I'm going to go walking on the moon. It feels a bit heavy, but it's a real pleasure to talk to you and share with you the outcomes of the transfemoral cohort of the Intrepid mitral study. And really, I do this on behalf of the investigators who enrolled in this study. These are my conflicts of interest. So we all know that transcatheter mitral valve replacement is an important technology for patients who can't be treated with edge-to-edge, but possibly in the future, even for patients who may be good edge-to-edge candidates and who we want to get rid of mitral regurgitation. You saw the early data from Thomas of the transapical data showing really good outcomes. There's patients out to 5 years with this valve, and the valve is doing what we expect it to do, which is eliminate mitral regurgitation. We all also were concerned when we saw the transapical, not only with this valve, but with other valves, that access issues are a problem. Putting a big hole into someone's ventricle when they have a low ejection fraction leads to bad outcomes. And so we all wanted a transfemoral system, and that's what I'm going to be talking to you today, is showing you some of the data from the first patients treated with the transfemoral system. Thomas mentioned it's the same valve. We have two sizes, the 42 and 48. Those were the valves used in the clinical study, and also the valves that are used in the tricuspid. It's the same valve. It has this double stent design with an inner component that's 27 millimeters. It's a typical bovine 3-leaflet valve. And then it has the 35 French transfemoral delivery system. The transfemoral delivery system has the typical knobs one would expect in order to be able to flex, go down, get coaxiality on the valve. I think what's unique to me about the Intrepid valve compared to other valves is the way it anchors. Because it doesn't use leaflets really to anchor the annulus. It anchors on the annulus, but it doesn't require leaflet capture. It doesn't require a two-stage procedure. It's a single-stage procedure. And so it allows you, once you across the valve, once you get coaxiality, it actually allows you a very predictable deployment of the valve. These were the sites that enrolled in the transfemoral cohort. They were all sites that had experience with the valve as part of the APOLLO study. And the early feasibility study is essentially what in the old days we would call a first-in-human study, right? It's the first patients treated with this approach. Usually the FDA will allow us to do about 30 cases, sometimes more, but we did 30 cases in this study. It was non-randomized, prospective. It had everything we would expect for a clinical study, such as an independent core lab, a event adjudication committee, so we really know that the data has been checked. You also see the key inclusion and exclusion criteria. I'll just highlight a couple for you. Patients had to have severe, moderate to severe, or severe mitral regurgitation. They also had to be high or extreme risk. So this was a study in high or extreme risk patients. So you'll see them when we see their age and when we see their STS scores. They had to have a life expectancy of 12 months. Obviously, they had to be good anatomical candidates for this valve. We excluded in this cohort severe prohibitive MAC, patients with severe TR or severe RV dysfunction, and importantly, an ejection fraction had to be 30% or more. So here you see the patient flow, 30 patients enrolled. One patient had to have the valve removed intraprocedurally because of valve migration. The other 29 patients then went on and had a successful implant. The 30-day data, though, refers to the entire rolling cohort. So when you see the percentages, we're talking about 30 patients at 30 days, because even the patient without a valve is still adjudicated to 30 days. We then will also show you the one-year data, and we'll show you the data on the patients who have arrived at one-year follow-up. Those were 14 patients. But also, I want to be clear that the data we show at 1 year was based on when the data was, the data set was taken from the database and all the events were adjudicated. And that's really important when I show you the outcomes. I want to highlight a couple of things about that. Here you see the patient characteristics on the 30 cases. Patients were elderly, they had high STS scores, they had all the complexity we'd expect in an elderly population who was high or extreme risk for surgery. I think a couple of interesting things I'll mention was that 60% of cases had primary MR. Why do I say that's important? Well, it goes back again to what I said about how the valve anchors. The fact that you don't need to capture leaflets means you can treat patients with primary mitral regurgitation, which can be a challenge for other technologies that need to capture the leaflets. A lot of technologies exclude patients who have prolapse and who have primary mitral regurgitation. When you look at the average ejection fraction, 50% with a range of 41 to 57, and about half of the patients had atrial fibrillation or flutter. Here you see the procedural outcomes. So, time to delivery, 42 minutes, really good. Majority of patients were treated with a larger valve. Balloons were used to dilate the septum, because remember, this system, it does not go over wire. We take a large sheath across the septum and then have the delivery system delivered into the atrium and pull that sheath back, but there's no wire to get us across, so we need to get the septum nice and big. By doing that also, there are large ASDs, and I think most of us feel more comfortable closing those iatrogenic ASDs because they are large. The average length of stay was 5 days, and majority of patients were discharged home. Like I mentioned, 29 out of 30 successful implants. So here's the 30-day data. Sorry, no, not yet. Yeah, here's the 30-day data on the left, and the data to 1 year. And I got to point you, because you'll see it better than I can on my smaller screen, to the fine print, because the fine print is really important. We show a 0% mortality at 365 days at 1 year, but like I said, this data reflects to when the data was exported to the database. We actually have had 2 mortalities in the study. One after 365 days, at 375 days, a patient who had a relapsing lymphoma and worsening heart failure. And then also a patient that, when we have the data out again, will be captured in that mortality, who died at 232 days. So the mortality, even though here says 0, I just want to be clear, the great thing here, we're not trying to hide data away. We want to be as transparent as possible, because I think we're all learning about who these patients are and what the outcomes are. However, when you look at everything else, myocardial infarction acceptable, major vascular complications, 27%. Maybe we can discuss why that is when patients have a surgical cut down. Acute kidney injury, 0. Reoperation or reintervention. There was one other patient, which I'll talk about in a second, who had to have the valve removed for left ventricular outflow tract obstruction. And I think it's pretty interesting why that happened. There was one case of valve leaflet thrombosis, and at 1 year, 22% cardiovascular rehospitalization. The valve, though, did what we expected it to do with TMVR valves. It gets rid of mitral regurgitation. And so you can see that there was no patients at 1 year or 30 days who had moderate or severe residual MR. Majority of patients, over 90%, had no MR. And they had no paravalvular leaks. That's what we expect from TMVR. As you heard from Tamar, one of the common reasons for excluding patients for most of these technologies is the risk of left ventricular outflow tract obstruction. And with all these devices, we really do try and predict who is the patient who's going to get left ventricular outflow tract obstruction. We simulate putting the valve in, and we try and figure out. I love this slide when I saw the data from Medtronic, because what this slide makes me realize is we know nothing yet. We have still so much to learn. Right? Because here's a patient who we thought was not going to have left ventricular outflow tract obstruction, then has to have the valve out. Other patients who had dynamic left ventricular outflow tract obstruction, where it was there and then got better. So I think there's still so much we have to learn about how these valves interact with the left ventricular outflow tract. Gradients remain low, 4.3, which is great for the mitral valve. And patients felt better. You see the New York Heart Association class improving, and we will have other quality of life data in the future. So in summary, hopefully I've shared with you some of the initial data of the first 30 patients from the transfemoral cohort. And I think what the data highlights is high rates of implant success, low mortality, no strokes, near complete elimination of mitral regurgitation through 1 year, and improve NYHA class. The vascular complications, I think, still remain an issue, and I think Thomas showed you, how we get to Mars now. We're going to have a 29 French delivery system. I can't wait to get away from surgical access and to have percutaneous access for these procedures, because as you see, having surgical cut-downs doesn't prevent vascular complications. So I think the future is transfemoral delivery for this. That's now the standard in the APOLLO study, and we look forward to sharing more data with you, both for this system in the mitral and the tricuspid valve. Thank you so much.
Thank you. Thank you, Asim, for this fantastic, and Thomas for this fantastic ride into the journey of Intrepid, but also the differentiation, what we can expect from a transfemoral access. We also learned that there are still challenges, and one of the main challenges of replacement still remains, in the mitral space at least, left ventricular outflow tract obstruction. Now I would like to hand over for the discussion to be moderated by my dear friend Alison Duncan, who has a high experience long-term also in replacement techniques. And Alison, you've recently published actually a paper on the preparation of those patients pre and peri-interventionally, because we have to see that we have to avoid underfillings of these ventricles. And I think one of the key messages that we've seen, that we had only one fixed LVOT outflow tract obstruction, but we had 3 dynamic ones that disappeared, is perhaps that our approach to the cardiovascular anesthesiologist and to the management has to be, even while we have patients with severe mitral regurgitation, that we need fluid during the procedure. So this would be the first topic for you now to lead the discussion, and I can again encourage the audience to use the electronic means to engage and also use the microphones so that we have interactivity here. Alison, please.
Well, thank you, Stefan. I didn't realize that was going to be a free-flowing session for me. I thought my job was to integrate you guys into the questions. So please do, come up to the microphone and ask some questions. But just to kick off the way you're thinking, I'm going to come to what you just said, but I was just thinking about taking a deeper dive into what you were saying, Thomas, about the first phase. So, the mortality was double figures at the beginning. So, some of that will be due to screening. So you said what the screen failures were, but you didn't say that what percentages were. And I just wanted to know roughly what percentage in the very first phases were screen fails. I know that they were annulus and LVOT, but what percentage, just so we get an idea of how much screening effort goes in and how many patients go through.
You could do a poll, actually. I would like to have the audience interact, so ask them. So I offer you 3 solutions: less than 30%, 30 to 70%, 70% or higher. So you can vote on three topics now. First, less than 30% screen fail rate in the beginning, of course, of the therapy.
Is this a raising your hands exercise?
Yes, exactly.
Okay, so less than 30% screen fail. Who thinks? Okay, more than 70%, did you say?
Or between 30 and...
I was just going to get the rest was in the middle.
Okay, okay, we'll do it that way.
So more than 70% screen fail rate. Yeah, this is exactly it. So this is part of the problem. So these were sick patients. You said they were secondary mitral regurgitation. So there's a high screen fail rate at the beginning. You know, you've got a high mortality, and some of that might be due to apical access, but some of it is due to patient management during the procedure. I mean, this literally is like turning the light switch on and the light bulb comes on. So they've got torrential mitral regurgitation, and they've got none. And this is big hemodynamic shifts at the, you know, within seconds. So this requires complete collaboration work within the heart team, the implanting team, the imaging team, and the anaesthetic team. So definitely that's that case. But in order to keep to time, I was just thinking to then switch it, then a deeper dive into what you were saying, Azim. You know, we've been honest, there's one death in 1 year at transfemoral, so this is a rate of about 3% as opposed to double figures with apical access. So, you know, we've got complete elimination of mitral regurgitation at what cost? Probably less than 3% mortality. Does the panel think that that is a great outcome?
Yeah, we have to be cautious, but Azim may elucidate to this. This is, of course, a small cohort, but the trend that we see is extremely encouraging. Azim, could you highlight a little bit on this?
Alison, you know, I think we were all very concerned when we saw double-figure mortality rates with the transapical cohort, but not only with this valve. I think you look at all the TMVR data, and that's what you see. We're seeing these mortality rates in the 20s. Some of that, I think, is the transapical access. Some of that is also when you select a group of patients who are not candidates for edge-to-edge and who are high or extreme risk, aren't you also selecting a group of patients who have a lot of pathology and a lot of comorbidities and may do poorly no matter what we do, right? So I think there's some of that. But it's really reassuring, though, to see that, you know, these patients did pretty well, right? I mean, the patient in the 30 patients we enrolled, there was no procedural mortality. One patient had to have the valve out. Another got the valve out because of LV outflow tract obstruction. It's reassuring, but it's 30 patients. I think as we enroll more patients in APOLLO, which now will be transfemoral only, I think we'll get a better understanding, and we'll be able to take away the part that's related to access.
Alison, this remark is very important, but I mean, keep in mind that surgery is still the gold standard. In some patients, it's a high rate of mortality. This is the price to pay. We want to go to a less invasive procedure, which is TMVR. We reduce the rate of mortality of complication, but we still are not able to eliminate it. And then you have to make a balance between the efficacy, the elimination of mitral regurg, and the learning curve and the complications that we may face in the beginning. So is it worth it? I mean, having at this stage the risk of a bit higher mortality, as you've said, but being able to eliminate mitral regurg, I think everybody agrees that we should eliminate mitral regurg and not only reduce it.
So I think this is the conclusion I was trying to get at, because, you know, this is a superb and very exciting area to be able to avoid transapical access, still in high-risk patients, but having mortality figures that are less than 5%. You know, it's a beginning, but it's great. Now, just quick 2 specific questions. One is, you're obviously going transeptally. What is the percentage of ASD closures? And does this affect future thinking about the lifetime management of the patient, potentially future need, let's hope not, for valve-in-valve intervention?
So I think you saw from the data, I think we've been, most of us, extremely cautious and not leaving big holes in the septum. So I think that, you know, the rate was close to 80% of closure. Does it affect future procedures? Yes. Wherever you put a device there, it's a challenge. And I think, you know, that's another area for innovation. We always talk about innovation at this meeting. Maybe we'll have devices. Well, not maybe. I know we will have devices because I've seen some of them that will allow us to close the ASD and re-access the left atrium. I don't think it's a concern for me right now, because look at the cohort of patients we're treating, right? This feels back like the PARTNER 1B days, where, you know, the valves outlive the patient.
But I think this is all part of the learning curve. And as we move on, and we saw in the last part of Thomas' description of the journey, we saw that the next year we will follow from a 35 French access down to a 29 French access. And with all our experience that we have in transeptal treatments, we know that we will get smaller, and getting smaller means not to close potentially in the future, also the ASDs, and also to use different devices that allow re-access. So there are Gora occluders that we can repenetrate that have little metal, and we use them regularly in our institution. And for other instances like TAVR in ring, TAVR in valve, we stopped to close the ASD. So I think this is the future path, and we saw 73% closures. This may go down. So I invite Alison back to the table.
Just one more quick question, sorry, Stefan, just because it's important, it's been from the chat, is what is the incidence of device thrombosis and what is the anticoagulation regime?
So in the transfemoral cohort, I'll speak about, because I showed the data, there was one case. We currently are anticoagulating all patients after the procedure, and how long that needs to be, I don't think anybody really knows. We've been doing it for 6 months now. I do feel bad, though, because we do have a colleague who stood up to ask a question, so I'm going to shut up.
Yeah, so...
Can we get the microphone on? It's on. Yes, now it's good.
Can you hear me? So 15 years of structural heart prime time now. But what we learned from our left-sided interventions was that the largest complication was vascular. That didn't really happen so much as we started on the right side with the TEER, because it was 28 French or so. But as we started going to 30 French and further on, there's been clearly a signal of vascular complications. And most of you guys have gone to surgical access, which our lesson from the other side was surgical access is not without complications. So now, could you, Dr. Ladeeb, talk about the vascular complications that you had, but also what is your plan for the 29 French? Are you going to just do the Z-stitch? Are you going to do per-close, or what are your thoughts about it?
That's a great question, and I think we have to learn from our mistakes and what we learned on the left side, like you said. We've already, you'll be surprised to know, there have been a couple of cases already with this device being so large where there's been percutaneous access. It's been done well, and there have been no issues. I reviewed the complications because I knew someone like you was going to ask me what the vascular complications were, and most of them were hematomas. Okay, that happen afterwards. So surgical access doesn't stop you from getting bleeding or hematomas. And I think there was one DVT as well, which for those of us doing surgical closures now, I think we're always trying to check and make sure that if we do a patch or whatever closure, there's flow at the end of the procedure. With the 29 French, it's going to be percutaneous access.
But
we have to move on.
A couple things. Just were there any large dissections in IVC or?
No.
No.
And then are you planning on per-close, or how are you going to do the 29?
Probably double per-close. And probably, and it's obviously double ProGlide and a suture as well, a Z-suture.
With no further ado, even though we want to encourage the discussion, and for the next part, after the next two talks, we have another session of discussion, so I encourage you to start earlier. Also with your questions, I would like to hand over to Anna Sonia to give us some updates on the APOLLO program, and also present us some case series that we get an impression of how the valve is being implanted, and then we move to the surgical perspective.
Okay, so just to, you remember this slide? It was already presented by Thomas, and now the APOLLO design is dedicated to patients that are not suitable for surgery or for repair. So this is the principle, and I would like to focus on the fact that there is the MARC cohort, which is, I think, it is one of the most important cohorts, because we really are not able to repair these do the repair with these patients. And this is a summary of all the morphologic aspects that we are not able to guarantee an optimal success with repair. And as I said before, most of them are MAC. Then patients that have already the initial stenosis of the valve, or that have some cleft or multiple jet, where we think that the optimal result is not going to be reached. So they are not all of them, but there are many. We know in our labs that we unfortunately have to say no to some of these patients. So just to reassume, we have 4 cases, just to show you how the implant and how the result can be in this kind of patient. Here is one. It is a female of 79 years old, and you can see at the morphology that this is a typical rheumatic feature of the valve. It doesn't move very well. It has already a gradient over 5 millimeters, a multiple jet, and so this is not a typical patient for repair. Here are the measurements of the annulus of the valve. It is quite round and shaped. And this is something that probably it's going to be more caused by the big franchise at the moment, but probably later on, when the franchise will be reduced, we won't be necessary to look exactly all the route of from the venous, femoral venous, to the inferior vena cava. And here you can see the moment where we have a balloon that you inflate to enlarge a little bit more the septum, and the typical point where you puncture, which is posterior, inferior, around 4 centimeters. Here you begin to see the delivery system that gets inside the atrium for 5 centimeters. And then you see at the beginning, just over the septum, the guiding catheter, and then the internal catheter that goes forwards, and then it begins to bend. You can follow this in the multiple views or in the X-plane, and you can see that you are able to bend it and to position it perpendicularly exactly in the middle of the mitral valve. And then slowly, you open the first part, the atrial part, and you can see that you arrive in a moment where the 2/3 are opened, and then after that, with, let's say, not a real rapid pacing, but sort of 150, 160 beats, you end the deployment of the valve. Here you see the result of this patient, no gradient, no paravalvular leak, and this time no closure of the atrial septum. Again, we see a second case. This case we have a valve that we would not like to repair. Probably it would be impossible. There is a calcium, and there is a short posterior leaflet, already a gradient like the other one of 5 millimeters of mercury, but with a moderate severe regurgitation. Here the area is very small because the leaflets don't open very well. You can see here very well the very short posterior leaflet is around 6 millimeters. This difficulty in opening is due to a big bunch of calcium. So this is, I would say, a moderate MAC. And you can see here that the opening of the valve. In this view, it's very easy to see the perpendicularity of the device in the valve. And slowly it opens. And this, it's the result. You can see in the upper view the calcium that has been pushed against the wall of the ventricle. And again here, no closure with a very mild regurgitation left. Third case, this time we have a short posterior leaflet again, very short. You can see it in the first view. And there is a multiple regurgitation jet. I would say that with this patient, probably we could try a repair, but we would not reach a really optimal result. So again here, there is the opening and completement. You can see that the beat increased when you finish the deployment at the last third. And this time we have really a trace, little regurgitation left, and not closure of the septum. So on 4 cases, we really, 3 of them have done perfectly without any closure. And this is the last case. This has already, you can see a big bunch of calcium that's pushing the posterior leaflet. And there is a heavy fibrosis of both leaflets, and the valve is not able to open very well. The grade of regurgitation is very high. This is a 73-year-old female with a 3rd near class. Again here, you see the valve that is opposing its first part on the atrium, and then first slowly, and then at the 3rd, there is a beat, a high rate of 160, and the valve completes its opening. This time, the septum has been closed. It was adjudicated. I mean, we don't know exactly the hemodynamic. Probably sometimes we should not close if you have, the dimensions of the tear, but you should wait and see the hemodynamic of the patient. So probably would be able to reduce the numbers of patients that need a closure. And here are the images of the valve, completely opened nicely. No paravalvular leak in none of these 4 patients. And here you see the imaging of the implants in the septum. So I think these are nice 4 examples of a patient that we would not treat until a few years ago.
Anna, thank you very much for this excellent overview. And just to get an impression of what kind of patients are being treated, we have to highlight that the Euroscore and the STS score were here in the medium range of 5 to 6. So now it's my pleasure to introduce our heart surgeon from our center, Hendrik Trede, actually to give us the view. We've seen that we can eliminate MR, that we have certain risk situations for a transapical, which is a more surgical access, that there seems to be, in a small cohort, I always have to be cautious, of course, but in 30 patients, there seems to be a huge advantage, actually, to go transvenous, which is a low-pressure access system. And we know from thousands, of course, also of TEER procedures on the tricuspid and 100,000 on the mitral, that venous access is extremely safe. And we're talking about, in concordance, of about 30-day mortalities between 0 and 2%. And this is reflected not only with repair, but also with replacement. And I think this is an important message. So how important is it for you as a heart surgeon, Hendrik, to eliminate mitral regurgitation, and who's the patient population that really takes the profit from this? Please.
Yeah, thanks so much, Stefan. First of all, I have to apologize for being late. It's not, I'm German, so I'm not usually late, right? But I had to be late because I had another presentation, another session, so this is why I came a bit later. Very short comment on the venous access. I think in this regard, it's even safer not to do a surgical cut down, because then the vein wall is really, tiny and then moves away from the implant, and this is maybe sometimes harder to repair. So I personally prefer to go percutaneous for these larger sheath sizes. Yes. But now to my talk. Actually, it's about elimination of mitral regurgitation, and this is not a surgical aim, it's a common aim of all of us, of course. We always want to eliminate mitral regurgitation as much as possible. When it comes to this, we of course know that mitral valve disease, mitral valve regurg, is a disease of either the valve or the ventricle. These are totally different animals, but they have one thing in common, that the recurrence of MR or the amount of MR after the procedure clearly has an impact, a negative impact on the long-term outcome. And there's no difference between primary MR and secondary MR when it comes to this. Both patient groups, if they are left with MR, have worse outcome. And then it's a hard team decision what to do, of course. There are various treatment options. We heard about this today, from medical treatment to surgical repair, surgery replacement, now even transcatheter repair and upcoming transcatheter replacement. So there's a toolbox we can choose from. And this, of course, opens up new perspectives now. But we're going to start to speak about surgical repair, of course. And there are a couple of lessons that we learned from surgical repair in this regard. First of all, surgical repair, if it's successful, has a very positive impact on long-term survival and reduces cardiovascular events, has been proven in thousands of patients. And we always, of course, aim to achieve the best possible result with no MR if possible. But we also know if there is a recurrence of MR or sustained MR after surgical repair, we come into the same problems that we have with all the interventional devices. We usually try to re-explore the valve dam to get rid of it, but if patients are left with this, there is a reduced efficacy of the procedure and also a reduced durability of the repair. So if the result isn't good, it's not good. What we also know is that there's a large undertreatment of patient population, right? Because if we would, operate on every patient who has even primary MR, we would have, tons of patients and would be hard to treat them. But in fact, we don't see them all. There's a 75% of undertreatment if you just go into the data and see how many patients are running around with severe primary or secondary MR. So we do not treat them all, and there's a clear need for other techniques, especially when the surgical risk is elevated. It is a class 1 indication for sure, because we have all the data from the past for primary MR. It is not a class 1 indication for secondary MR, and this is also with good reason, because again, here we're not treating not a diseased valve, we're treating a diseased ventricle. And the results of surgery in these secondary MR patients are not as good as with primary MR. So it's only a class 2B indication. But we start off with primary MR. If you do primary MR, this comes along with a very low operative mortality, what is good, and very efficient long-term options for those patients, especially when you really achieve a proper result. If there's no MR after the repair, then the result is absolutely comparable to the normal course of that same patient population without disease. If you have MR, it doesn't look this good anymore. And here you can see, even if you have more complex repairs regards to the anterior and posterior leaflet, the results over time are excellent. Once you can get rid of the MR, then the course of the patient is absolutely comparable to patients who have no mitral valve disease at all in primary MR. Maybe you go over this. Because it's more important for us to speak about secondary MR. Surgery in secondary MR is not this easy anymore. It is basically an easy surgery, but it does not necessarily mean that the result is a good long-term result for the patient. And we learned this again from the CTS NET trial, presented first by Mike Ecker, that compared in ischemic secondary MR, surgical repair versus surgical replacement. This was a 1-to-1 randomization. If that was done properly, I'm not so sure, but at least we have the data from this. Because I think some patients have been repaired, although there was no chance of a good long-term result for the repair. But still, we have the data, and the data show us that after 2 years, in those specific patients with ischemic MR, the recurrence rate of MR was 60% already after 2 years only, and that also had a negative impact then on long-term outcome. On the other hand, those who had successful repairs showed the best RV remodeling and the best outcome. The lesson we learned from this is that we have to find ways to find out before the repair of a secondary disease if the long-term outcome would be a good one or not so good one. And there are measures that we know now that tell us if a repair makes any sense or if we should go straight away for replacement. And maybe these same, the same perspective also accounts for the interventional techniques. I mean, maybe there are some patients who are just not good repair candidates, and where we should go, if anyhow anatomically possible, for replacement by first sight. So surgical intervention in secondary MR has a long-term risk of survival once you get the recurrence of MR. So the survival is much worse when you get recurrent MR, and compared to non-recurrent MR, and this doesn't come as a surprise. Also, readmission to hospital with the recurrent MR is, of course, much higher. So there are some lessons we can also learn from transcatheter therapies in the treatment of MR. I know this is something that you can discuss a bit controversially, but we know that comparing mitral valve leaflet repair technologies interventionally to mitral replacement technologies, at least when it comes to just looking at MR, that mitral valve replacement is more effective than mitral valve repair, because there is a certain amount of patients who do not end up with less than mild MR after the procedure. This is, what we have to accept. And this is now, comparing the two devices, MitraClip and Pascal. It is not a head-to-head comparison, for sure. There are trials going on looking at this. But you see there's a certain amount of patients who still have mild to moderate MR after placing one or the other clip technology. So how important is it for transcatheter devices to achieve the surgical standard of no MR? If you just look at the MR criteria, they tell us that 0 MR is optimal. Everything greater than 1 degree MR is acceptable, unless it's greater than moderate, then it's of course unacceptable. But at least you see from this wording already that there is a thinking that the reduction of MR down to 0 or trace would be the best aim to achieve. And while the TEER experience indicates that residual MR severity is also associated with a higher mortality. So if you go to those patients who did not have perfect results, the same accounts to the TEER population what accounted to the surgical population. The more MR you have, the worse your outcome will be over time. That has been proven in several studies and registries. This is not the case when it comes to mitral valve replacement. For the one device that you see earmarked, the 10-line valve, but also for those who are under investigation, like the Intrepid valve, we heard the data already, is definitely not the case. So there is no recurrent MR, first of all, but also no residual MR after the implantation of these devices. So that at least gives us hope. And this is also sustained out to 2 years. So I don't see this coming as a problem in the future. So in summary, we know that MR severity is associated with poor prognosis. Surgical repair is effective, but not available for everyone, and there's a large amount of undertreated patients. Residual MR following surgery, as well as transcatheter procedures, is associated with the worst outcome, so we have to have this in mind and always try to achieve the best possible outcome. TEER is, of course, very safe. I mean, this is the one point you always have to make. It's nobody dies from a TEER perspective procedure. This is at least something we have to have in mind. But it may not be as effective as the replacement of the valve. And we should find out which patients, also for TEER procedures, are prone to have a very good result, and separate them from those who are maybe not good TEER candidates. In suitable patients, transcatheter mitral valve replacement may become a very valid alternative. We are maybe not there yet, but I think we're going to come there. And future randomized trials, of course, are needed to really find out what the landscape is looking like. Thanks so much.
Hendrik, thank you very much for this very balanced and good overview. And only one percentage was not completely correct, and this was the 2D trial. The class 2D trial was a comparison, and actually the primary and the secondary endpoints were being met. But of course, 9%, 10% more than mild MR are possible with even those patients that are treated, and this was a primary group that responds, of course, best. And we have to look over the time course of 1 year, 2 years, 5 years, and perhaps 10 years' time, what will be the most effective therapy. But you raised the most important point, and this is we have to look into safety. And here, Thomas, actually the transition to the transfemoral route is quite promising. But of course, these numbers are much smaller than what we've seen in TEER. So I would like you to do rapid fire sessions, as we have 4 minutes for discussion. So from your presentation, Thomas, what would you like to take away for the audience as the key points in the journey? The journey has taken a little bit longer. It has a very nice goal to go for. So what do you think will we see in the next 2 to 3 years as we're adding European patients to these trials? Where do you see the therapy with replacement in 3 years' time, Thomas?
it's
20 seconds.
Yeah, it's gonna be biting more and more indications from the edge to edge, because we're gonna be much more optimal. And I think this is mandatory for lifetime management of mitral valve disease.
Okay, Asim, what did we learn from the US experience with Apollo, and what could Europe contribute to this experience outside numbers? Asim.
Yeah, I think the more physicians who do this procedure, the more they add their own finesse and their own ideas to it, and the more we learn. And so, as someone who's, I guess, still European and American, I don't think it's about Europe and America. I think it's about how do we learn together and make sure that what we learn is transferred back and forth so that patients are always getting the best therapies possible.
As audience is first, I would like to invite you, but also only 10, 15 seconds for the question, please. Can we open the mic?
Very wonderful session, very nice. Now that you have the transeptal option, are you going to go back and add a randomized arm into the trial? And I'm sorry if you already covered that. But,
we covered this.
When are you going to start that? And
this will be in about 1 to 1.5 years' time. So the single-arm trial in Europe is first, but a randomized trial is already underway and will be added to this experience. So
and the comparison group will be surgery?
Edge to edge.
Edge to edge, got it. Thank you.
Okay, which is only possible if you have a very safe alternative. So this relies heavily on the transfemoral approach, but this is, of course, a very positive outlook, and it's a challenging situation. But of course, it will be more efficacious, and we have to see if it's as safe as. So these are the main points. So there's another one. Very good. So we see rapid fire sessions are even better. Please go ahead. 10 seconds.
How do you account for the difference in acute mortality, for example, in between replacement and repair in the surgical trial of ischemic MR? Do you think it is afterload mismatch and the contrast in MR reduction, or do you think it's sort of geometric distortion of the ventricle that's done that? And are we seeing a distinction between TMVR mortality acutely, because all the numbers are very good, and surgically?
Yeah, perhaps it's a question to Henrik.
I can shortly answer that. For that particular trial, we're talking about the CTSNet trial. I don't think it was well managed because the randomized patients that should not have been randomized. So I would not, take too much detail on the difference in mortality. I think have been 2 different patients group, and not all of them should have been randomized. So it gives just an impression that if you just, go for repair, what always, possible by the first operation, the first result will always be no MR, but the recurrence rate is very high if you don't do your homework properly beforehand.
Okay. Next is Anna. What are your key lessons? You showed 4 cases. They showed extremely nice results, but we have, of course, the problem of screening patients. Who is the patient for you to put into the trial as a single-arm trial to gain more evidence and more information on replacement in addition to repair?
To what we have now.
To what we have now. Enhancing the toolbox with this trial.
Well, probably we will have to increase the number of patients that, what I call borderline, the ones that probably we could achieve a good result with TR, but they are not perfect, and so slowly try to shift and see what happens.
Alison, you are a promoter of replacement in the transcatheter space for more than 8 years, and you've seen patients with 8 years follow-up. What would be your key learnings in 25 seconds?
No pressure.
Go transfemoral transeptal if you can. Obviously, that the patients do have apical access issues, so if you can go transfemoral transeptal, do it.
Okay, thank you very much. We have 1 minute left, and I think we're in time. These were perfect remarks, and I would like to conclude. We went a journey. The journey has taken longer than anybody anticipated. It's been 8 to 10 years of replacement. It has been more challenging in the time span than TAVR procedures, but we have learned similar lessons. One of the lessons is transapical is a more invasive approach than a transfemoral approach. A transvenous approach is less invasive than a transarterial approach. And I think we're on the way to have an experience now of approximately 2,000 transcatheter mitral valve replacements. We know the main challenges are LVOT obstruction and the adequate size. So if TAVR was taking the car to your goal, mitral is taking the plane or the rocket to the moon. So it's more difficult to start with, but after good preparation, you can reach your goal, and the Chinese have made it too. So I think we'll have an Apollo mission that will reach its goal, and we have to look what we see in front and behind the moon. Thank you very much for your kind attention. See you next time with more information.